Speakers we've had this morning and through the concurrent sessions. I think there's been a wealth of knowledge and wisdom and experience that's been shared, and I think this kind of event where we bring people from the consumer, family and carer backgrounds and lived experience backgrounds with clinicians and all have us come together and share our knowledge and experience to try and nut out how to progress these issues and to advance our endeavours all together is very important. So I feel very privileged to be a part of doing that and being a part of this day. What I'm going to talk today about a little bit is these issues very much of when we have an event like this, how we bring things together, how we bring together research and training and public health service provision along with the needs of families and consumers and carers and how we kind of progress things. That's a topical issue in South Australia. In the last 5 to 10 years, there's been a movement of different international and national guidelines for provision of borderline personality disorder treatments and services around the world, the United Kingdom, United States, throughout Europe, and the NH and MRC in Australia. And in South Australia, a couple of years ago we released our policy, and then there's a sense of a lag and how we kind of actually actualise some of the things that we want to realise in terms of services and opportunities for people to get treatment and support and those kinds of things. So part of what I want to talk about today is what the future holds moving forward, and also what some of the challenges are as well. And I think I'll be echoing a lot of themes that have come up over the course of the day in other people's talks as well. So just to initially think about this, I guess we're here on the 5th National BPD Awareness Week Conference, 5 years, 2010 to 2015. In some sense, that's relatively late in the day. Sometimes we can think about BPD as this new kid on the block that's knocking on the door of governments or different services trying to get help and support, and there's this desperate need. But actually the disorder has been around for decades, and the history of the disorder and the term borderline personality has been around for over the post-World War II period, essentially, and I'll talk a little bit about that. So what is it about this kind of lag, and we can be here in the present moment all discussing the sense that there's not enough being done, and how do we kind of integrate things better and achieve better outcomes. So what's that about? There's this sense also that the borderline issue is very, very prevalent. It's everywhere, and so why aren't things being done? Is it the patient of our time? Is it the most important issue to address? But why isn't it being addressed? Why are people with these issues the outsiders often? They're around in all sorts of services. They present very frequently, need support and help. The families and the carers need support and help, but it's not happening. Why not? And that's some of what's been expressed today in different fora over the time. Going way back before this modern era of these different specialised therapies that are talked about and offered into the 1980s, it was already felt back then by some of the experts that the literature on borderline personality was enormous, and it was hard to get our heads around, and there was so much being written about it and talked about it. So there's that sense of why aren't things being done? So we know that it's this unifying concept, a lot of things, a lot of complexity, a lot of different ideas, a lot of different issues for clinicians and individuals coalesce under this idea of BPD. We know it can be readily adopted, sometimes it can be readily avoided. It's often pejorative, and it makes the diagnosis and individuals diagnosed with it overrepresented. If you do a Google search on personality disorders, borderline's very, very prominent. It's well researched, there's a big literature on it, but nevertheless there's this feeling that there's exclusion. What's that about? When I did the talk in 2012 here, I talked specifically on, well, what does borderline actually mean then? I'm not going to repeat that talk, but we've noticed that this term did emerge from North America in the post-World War II era. There's something about psychiatry and psychoanalysis coming together. Robert Knight, who was one of the initial theorists of borderline pathology, who wrote in the early 1950s, he was both the president of the American College of Psychiatry and the College of Psychoanalysis. So it's something about psychoanalysis and psychiatry coming together. And there are also these elite institutions in North America on the East Coast that began to theorise and study and write about borderline personality disorder. Why did it arise in North American culture at that time? I think a lot about the history of ideas in the things that I write, and I think about culture boundedness. What is it about that period of North American history that made borderline personality disorder arise? We know that America is a country of extremes, and it's got very kind of ambitious kind of ideologies in terms of universal rights and civil rights and universal access to different kinds of opportunities and supports, the American dream, all of that kind of thing, and yet it's a culture of extremes, extreme neglect, extreme disadvantage, and extreme differences in opportunities as well. So if the borderline kind of diagnosis arises in this kind of context, perhaps we're seeing that there's this very kind of contradictoriness that's at operation that we still see today when we talk about some of those ideas I was talking about feeling excluded, is the idea that the people that have been exposed to all sorts of adversity or neglect or disadvantage, or have underlyingly as a result of that different kind of personal or psychological issues. It can be around trauma, it can be about other developmental issues. There's also the opportunity to request help, to expect help and need help, and the idea or the aspiration that the community can actually offer that help. So there's this interface then between disadvantage and neglect and other problems with the hope and the promise that something can be offered to deliver to fix it. So perhaps in our kind of domain of mental health and psychiatry, this is one of these issues at the interface where we have the promise, we have the knowledge, we have the expertise, and we have the aspirations potentially to be able to solve things and fix them, but we're met by limitations and exclusions and other kinds of problems. So that's one of the kind of intrinsic dynamics, I think, that revolve around borderline personality issues. I know there's this big history of the concept evolving. I won't go into that in too much depth, as I alluded to, but going along from history of psychoanalysis and psychiatry in the 1940s and 50s, and Otto Kernberg being quite instrumental in theorising about the disorder in the 1960s and 70s before it appeared as a DSM category. So it has this long kind of history with all of these different trends that made it suddenly kind of appear as a unitary concept in the DSM in 1980. And it's only been subsequently to that, in more of the 1990s and the 2000s, that these specialised therapies to kind of be researched and treat the disorder have arisen as well. So now it kind of exists as this concept that we can kind of understand and treat, and it seems like a natural kind of problem or disorder that needs all of these supports and services. Andrew Channon yesterday in his talk talked about it having all sorts of different kinds of problems potentially as a construct that we can use, but it's good enough. It's something that we can bring a lot of kind of approaches to treatment and to services and to psychotherapies together with the needs of the individuals that can kind of coalesce around this problem together to do something about it. We need some kind of concept, and this is the best one we have. So BPD is what we want to run with, and it's very important. So where is the BPD term adopted now? These kinds of difficulties it coalesces around complex and unstable, erratic, suicidal, self-harming individuals, often not readily explained by what used to be called Axis 1 psychopathology, mood disorders, anxiety disorders, psychotic disorders, those kinds of things. It represents a group of complex treatment-resistant individuals, but perhaps not so treatment-resistant, with an array of chronic problems related to constitutional factors and developmental adversity who require intensive psychotherapy and coherent, structured support from healthcare providers and social services. So now we have an increasing optimism that these forms of treatment and support are helpful for this group. And to further the implementation of these services and supports, ongoing advocacy and collaboration between professionals and consumers is needed, where this will promote a sense of identity and belonging for the consumers and motivate the pursuit of excellence in training and research and service provision for the professionals. That's what we're here for today, and that's what we're all about here. nevertheless, the individual's perspective, what do they experience? And we've heard some very, I guess, evocative and memorable accounts and narratives about this from the perspective of consumers and carers, about the experiences of stigmatisation and blame and the repetition of cycles of abuse and rejection and abandonment and the overwhelming states of fear and pain and rage and the constant battle for control and security and safety that they experience, a constant battle for a sense of stability within oneself and in one's relationships. And there's this overwhelming need for validation and support and respect, and a sense that people are collaborating with them and committed to them and understand them. And the clinician has their own difficulties. There's so much fear that clinicians experience and a sense of helplessness in the face of these kinds of difficulties as well. That's important to acknowledge those things because our own defences become active in dealing with these issues. We have a great sense of confusion and anxiety and stress, a sense of chaos and risk and danger, and the imperative to act immediately and not necessarily be able to sit with the issues and formulate a coherent sense of how to approach them. So when the borderline diagnosis becomes operative, we've heard of lots of different conflicting narratives today about, well, some clinicians are scared of using it because they think it's harmful, or some use it in a blaming or stigmatising way, or other people talk about it with a coherence and an empathy and engage in a dialogue with the individual about the diagnosis to make it meaningful for them and make it a shared process of understanding. So there's lots of ways that the diagnosis can be used, and it's always important to think about that very carefully. When I engage in any kind of assessment or psychotherapy, I make it a kind of an object of discussion with the individual, and I kind of make them aware of my own conflicts or my own reservations about the diagnosis, or my own personal thoughts about the diagnosis, and I'm very interested to hear theirs as well and have a discussion about that rather than impose the diagnosis. Clinicians can be aided if they have the sense that there's a coherent approach to how to deal with things, and they can tolerate the sense that there's a risk there, but they have support from their peers and teams and institutions in the background, and they can feel optimistic about positive outcomes. There's always a sense with these issues that very immediately you're kind of engaged to act, and you've got to focus on, well, God, what level am I engaging with this problem? And it causes a lot of anxiety, that sense of where are the boundaries? What I need to clarify is what I can do or I can't do. And it's very intense right from the beginning. It can be that sense of, I haven't got time to think about opting in or out of this or taking my time about this. Often there's a really immediate imperative to engage and to collaborate, and that can be overwhelming for individuals, when they turn up to work, but we can obviously remember that it's a hell of a lot more overwhelming for the people that are suffering and wanting to engage with you. So borderline, there's borders there, aren't there? Boundaries and frontiers between the self and other, between feeling and doing, and there's this need to engage. People come for help, they're in crisis, and you need to somehow engage with them as a clinician and engage in dialogue and collaboration and commitment, show commitment and a sharing of responsibility. That's not light work, it's challenging work, and everyone needs to kind of have a sense of commitment to that and be aided to be able to do that. So what has come out, I guess, in a lot of discussions from all of the different perspectives today is that relationship's fundamental. This is a relational kind of issue. The person suffers in their relationship with themselves, how they regulate their emotions and feelings and can perceive themselves, their self-concept, and also the relationships with other people as well. There's a lot of instability there, and that's of course implicated in the treatment relationship as well. It's a relationship, so we can have a sense of a dispassionate form of work or a particular kind of authoritative stance we have as a clinician, but no, this is a relationship and we need to be prepared to enter into a relationship. Relationships can be extremely complex. An individual can have a sense of who they are and what they're expecting and what they need or want or what's going on for them and how they see you. And some of that can be kind of distorted or disturbed in the moment, and it can be coloured by trauma, it can be coloured by all sorts of experiences of how you're approaching things. So this is a picture that a friend of mine painted that I want to put on the cover of the book I'm producing, where I discuss borderline pathology and the borderline concept from a historical and a philosophical perspective. And I like the picture because I think it symbolises all sorts of issues about relatedness and relationships and that kind of thing. I think we've got quite an arresting, a lot of people that have looked at it say it's quite a arresting and confronting kind of image, and the figure in the corner there, the bunny girl, is someone that's, it's quite arresting to look at, and there's that sense. It makes me think that immediately, if you're thinking as a viewer of this picture, what do you think about, or how you understand that individual who's in front of you? You could say, well, immediately there's some kind of illusion there. That's, what's the bunny face about? What does that mean? And what's lurking in the background, in the open door, in the kind of in the murkiness of that background there? It makes me think of individuals that can kind of be in the moment in a relationship with you, where you can be perceiving certain kind of unformulated or unresolved issues that are sitting in the background, that might be driving the encounter and the relationship and what's occurring, and it's not how they're seeing it at the time, but you want to relate and engage with the person and understand things from their perspective, but also introduce this idea of being able to make links and think and understand what the bigger picture is, or the context, because sometimes people are very caught in the moment and caught in how they're seeing things, and some of your role as a clinician is to try to introduce context and introduce a bigger picture, and some of that can be helpful for borderline tendencies, the idea of making links and understanding things and relating with a person about things. That can be what's very important in the psychotherapeutic relationship. So this picture makes me think about that. Makes me think about a theorist, Andre Green, who talked about a core aspect of borderline issues as being what he called a central phobic position, which is this idea that there's a great difficulty in relating and linking and associating and thinking that occurs in the person's life and in the psychotherapy as well. And the challenge for the therapist is to sit there and tolerate that and try to work on that and overcome that. And that can be through all sorts of endeavours to relate with the person and help them think and understand and put things into context and associate what's going on for them at the time. And that can be extremely challenging work to do. So it's not something that is easy for either party, but it requires a lot of commitment. So there is this crisis of need that we talk about. There's a sense of individuals and families and carers saying, where can I go to get help? There's not enough help, there's waiting lists, there's inaccessible services or a lack of services, and often clinicians will be saying, where can I send these suffering individuals to get help as well? So we know that there, and I'll talk about this briefly in a moment, different types of specialised psychotherapy. Some are on offer in South Australia, or around Australia, but there's always a sense of inaccessibility. Some lucky few get into these services, others have to wait a long time. Sometimes it's not kind of individually tailored enough or specific to the needs of the individual. So there are those difficulties. In the meantime, we know that the majority of the treatment encounters and the interactions people have with health systems are these other things, everyday things that can be I think we heard about nocebos or kind of traumatic treatment, if you like, and treatment that's not effective in spite of the best efforts of people. So how do we kind of overcome that and make not only people have more access to specialised services that are on offer with that kind of expertise, how do we also create change in all sorts of treatment encounters, not only in the mental health systems, in emergency services, inpatient services, outpatient services, but also in the other health sectors as well, primary care and emergency departments in general, all of those kinds of areas as well. There's quite a challenge there. It's been very heartening to hear from other services and centres of excellence that talk about not only the special modalities of therapy that they offer, but also the integration and the synthesis of their programs into the broader health sector and the public health service provision. And I think they're the challenges that we have in South Australia that we talked about in some depth in the current session before, that we'd like to introduce. So yes, there's a lot of complexity in research. It's an era of increasing cross-disciplinary research and a focused on evidence-based manualised therapeutic approaches. There's seen to be a diversity of causes and lots of different paradigms of looking at these issues, and a diversity of specialised therapeutic approaches. We know that there isn't necessarily a single causal pathway that's necessary or sufficient, and there's research focus on genetic disposition involving different neurotransmitters around affectivity and temperament. We also focus a lot on developmental adversity as well, and chronic chaotic relations and a blurring of generational boundaries, neglect, trauma and abuse we heard so much about before. And of course attachment pathology is focused on a lot. And a lot of these research programs, and here are some examples here, translate a lot of those theories into things to target in their specialised psychotherapies. There's the trauma focus as well. So the modern therapeutic approach is the really high-level gold standard treatments, secondary roles for pharmacotherapy, but all of these therapies here, there's a wealth of options now, and they're all very well researched and they all have good outcomes. And as I tried to allude to before, there's some sense of then how do you translate the psychotherapeutic principles that a lot of these therapies have in common and are often overlapping with, to a general approach to good care in different contexts. The care that's structured, involves crisis intervention, is individualised and patient responsive. It involves setting limits and clarifying realistic expectations. It involves different teams that are involved. It's not just an individual therapeutic approach, and it varies from context to context. So I think we know a lot about these therapies, so I'm just going to cover these briefly. We've obviously got DBT, and that's operative in South Australia. We have some excellent DBT services in certain sectors of South Australia, and that's something that could be enhanced. We've also got expertise in mentalisation-based therapies as well, and again, that's something that can be enhanced. And we've got some emerging interest in transference-focused psychotherapy from my background, spending some time over at the Institute in New York and starting to introduce that into advanced training. So we've actually got some of these therapies occurring or beginning to occur more frequently in South Australia. So yeah, I spent some time at this institute as a fellow in 2013, so I could see, not only learn about transference-focused psychotherapy specifically and how that modality of therapy is used. I've had quite a bit of supervision in that and been involved in ongoing kind of research and training aspects of TFP, but I also got to see how that kind of institute was embedded in a real-world service as well, in a public psychiatric system and private psychiatric system that's obviously extremely different to ours. And I could see, some of the experts, Otto Kernberg's in his mid-80s, but still working prolifically and still a very astute psychotherapist, and I could see it's very reassuring to see someone of his calibre fumbling and being anxious and feeling helpless and having the benefit of supervision with individuals with complex problems, and that's being normalised as a part of the process, and also having a group model of supervision and peer support as well that all good psychotherapeutic programs have in this area. And also having a very sophisticated model of the diversity and complexity of issues. Their structural model, where borderline personality disorder is just a small part of a wider group of characterological or personality-based issues. So there's complexity there that we need to acknowledge. So their model of therapy, the reason why I was interested in it and wanting to grow it a bit more is I think it's quite well suited to the Australian psychiatric context and having it in, it's laughing at the New Yorker cartoon here. I think it's well suited to the Australian context because it fits with opportunities in psychiatric practice that other countries don't have, in the sense that psychiatrists can see people individually for as often as twice a week in Australia, and if they can be supported with a coherent model and a framework in which to work, there might be more uptake in the private psychiatric sector to treatment, and there might be more opportunities for linking with something like a centre of excellence for service provision. So the services perspective, is BPD service provision costly? Specialisation and training and intensity of treatment prohibitive, and the research requirements as well. We know that there's literature out there that talks about the cost-benefit analyses and the prevention of adverse outcomes that can easily justify enhancing psychotherapy service for borderline personality. So that aspect of kind of advocacy and lobbying is there and available and ready to translate into asking for more funding. We know that the complexity is very daunting, the idea, and we hear this, we don't know where these practitioners are or where the services are. I went from this service to another region and this happened, or I saw this person, they did something different to that person. Making things integrated and coherent and consistent is extremely challenging, not only within the public health sector itself, but then when you interface it with all of these other services and the private sector, so it becomes very, very difficult. But we know, and we've seen the examples of some of these other centres and services in the eastern states and overseas, that not only offering a specialised therapy within a program, but having this ripple down effect of an idea that this is a coherent psychotherapeutically informed approach across different service contexts to these difficulties can optimise outcomes and create better outcomes. So I think that's something that we should be interested in trying to advance in South Australia. So I'd say that BPD, there's lots of interest groups and lots of areas where not enough's being done, but I'd say something special about BPD is it's really emblematic of the challenge for public health systems, which the problem being that systems can replicate the same dynamics of instability, inconsistency, reactivity and lack of integration that are purportedly the hallmarks of the disorder. So what I'd say is actually this is in some ways, you could say, is it a culturally constructed problem, or is the lack of integration in our systems actually exacerbating the problem? Well, yes, I think it is. And I think some of the issues then around how we fix our mental health services and how we improve in terms of kind of integration and consistency and availability of support, we improve our health systems. I think that'll be fundamental, to improving the outcomes for people with BPD. And I think in a broader context that represents issues around social disadvantage, a bit like I was saying before about the history of this disorder, broader issues around social disadvantage, social determinants of mental health, and social, the need for further kind of social cohesion and social programs. So BPD isn't fixed simply by creating an army of specialised psychotherapists. It's about a trickle-down effect into integrating mental health service systems and general health service systems better, but then also thinking about the broader context. We don't want to be kind of utopian and think about fixing the world totally, but it does, relate to broader issues around social cohesion. And we've heard Andrew Channon talk about all of the social determinants of mental health and the social disadvantage and disability associated with BPD, going all the way back to its early emergence in puberty. And I think all of those factors in and of themselves are significant risk factors and co-determinants of these problems as well. So just some concluding remarks about where this all fits in South Australia. Yeah, I'm very motivated to advance psychotherapy training in amongst psychiatrists and trainees. I've been involved in the development of the policy and the previous conference here. And really currently I'm interested in trying to develop in a role of being asked to chair an implementation process for a statewide service, really getting as many people on board as possible from all sectors, to try and create a critical mass and a central and coherent and cohesive kind of group of interested parties to try and advocate, come together and integrate what we're already doing very, very well into a common kind of alliance and a common purpose to improve outcomes and systematise things better. I think there's a lot of expertise here already and a lot of good things that are being done, but there's also a great level of need and a lack of integration and a lack of identity ultimately in what we're doing. So I want to help that become advanced. And the first steps of that are really to try to work with the Department of Health more to advance implementation and advance the commitment to a statewide system of care and developing a model for a centre of excellence for borderline treatments in South Australia. And initial phases of that will be involving setting up an advisory board with all local stakeholders and representatives from all of the sectors, consumers and families and carers, and clinicians and related agencies, as well as interstate experts, like some of whom we've heard speaking today, to be involved in this process. That's going to be established in the next year, and then also exploring different kinds of opportunities for collaboration with other sectors, university and training sectors, for example, and also other funding streams potentially in other organisations, to develop partnerships to further advance the idea of a centre of excellence. So, and really narrow down funding models for that over the next year, and lobby, and I think we're all good at that. And Penny Wright gave us advice about that this morning. We want to find a way through mechanisms like the BPD Foundation to come together to lobby in a coherent and kind of extensive way to advance all of this. So the underlying tenets, I think, of all of that are to make it as inclusive and collaborative and participatory as possible. Everyone's involved, and we have a kind of a shared voice to try to advance these issues. So the initial kind of way that I mapped that out and discussed that in the concurrent session before is a system of care that involves all of these facets, and I won't elaborate on them in great depth now, but it really, as you can see, it involves what we're doing already in the LHNs that can be optimised with different kind of care pathways and improved monitoring and a focus on particular patient groups. Can also provide tools and resources to improve ownership and a sense of empowerment and engagement and capacity to kind of work with these issues and own them, and with care pathways hopefully that adopt approaches to help community mental health services actually have a coherent approach when they receive referrals. Then there can be all sorts of interventions in education and training throughout the community, engagement and ongoing input from families and carers and consumers. And this kind of service, like the services you've heard about earlier on in the day, can potentially offer consultation and supervision, and the specialised services that are already occurring and can be augmented and optimised can be folded into this kind of system of care as well. So that's kind of a map initially of a whole range of approaches to systematising what we're doing already and what we need to add onto what we're doing already to create a kind of a systematic approach to BBT service provision in South Australia, hopefully with a centre of excellence backing that up. So that's all I'd like to talk about today. Thank you very much.
A different size pencil case for you.
Excellent.
Thank you.
Thank you very much.
So much
okay.
for your... Thank you.